Hey everyone, thank you for joining us live today. I'm joined by one of our amazing speakers and experts, Shelly Denes. Shelly Denes is a physical therapist who has a lot of amazing trainings with us, and so excited to have her on today so we can talk about gait imbalances and some really helpful tools that you can use both clinically but also in the community and at home for those. And so you can see on the screen there, that's our giveaway for the new Gait Clinical Mobility Harness Kit. You can get that deal through going to rehab.pesi.com/gait giveaway. I want to go ahead and dive in, Shelly, with you and just talk about, obviously gait, looking at gait impairments, and then also looking at tools that we can use clinically. Obviously, today we're talking about New Gait's clinical mobility harness, and what New Gait's done, it's really unique in that they've created something that's able to adapt itself within different phases of the gait cycle. And I kind of want you just to kind of explain a little bit more about this specific tool, how it's helpful for people when it comes to gait, and how you can use it clinically.
Well, thank you, Evan, for having me, and PESI. So I've worked a little. I've worked with the New Gait a little. Well, I shouldn't say that, in different phases, and I've been involved with setting up some clinical, some educational stuff for it. And I've worked closely with the therapists that actually made it work very much in a rehab setting. New Gait was originally created by a gentleman by the name of Benga Adiko. I hope I didn't mispronounce his name. And what they were using it is for runners to make them go faster and be able to carry stuff. And then there's some therapists in the upper part of Michigan, the Upper Peninsula of Michigan, kind of kicked onto it to see if maybe this could work in a rehab setting. And I've actually been up to the Upper Peninsula in Marquette and worked with 3 very phenomenal therapists, and one was an orthotist, to work with the New Gait to see what they're doing. So it's actually a bungee system. They're bungees. They have TheraBand or TheraTube on them with carabiners. So you can do resistance, you can do assistance. It has harnesses, it has a waist belt, it has harnesses, little straps around the legs, it can go around the feet. So you can use it as easy as for somebody that has foot drop. You could add stuff for posture, somebody's forward head or forward with their shoulders. You could put the harness or the straps around the chest area, bring them back up into a posture, and add resistance or assistance. It's pretty amazing. So it actually increases the tone, the muscle tone. It adds traction and pressure in the joints. So you're helping proprioception, you're helping muscle tones. If they're weak, you can assist. If they're a little bit tight, you can assist. It's fairly forgiving for tone. It's a pretty interesting piece of equipment, and you can kind of set it up however you like to do it. It's all very, very experimental. The other thing is it's not super expensive. The price you see on the thing, that's $750. That's for a clinical unit that has all the different pieces that you can do. And what's very nice about New Gait is they'll send a therapist to your clinic if you think that it's something that might be appropriate and show you how to use it. And they have videos, and they have all this kind of stuff. So it's a really, really nice way to make the gait flow. And then let's say somebody's doing better and they need part of it, they could buy a little part of it. Or maybe they don't need to buy it at all. Or maybe they're using it in the clinic. It has so many variabilities, but it works on proprioception. It works on muscle spindles. It works on the Golgi tendon order. It works on strengthening. It works on posture. You can incorporate it with visual stuff. You can use it in the parallel bars. The other nice thing is you take it outside, okay, and then teach the patients how to use it and put it on very easily. So it's a very versatile tool, and things have changed with it as it was created. And I think the company and the people that are in the company are very open to changes that need to be done. It's very, very nice. So
yeah, and you touched on a lot, and I want to try to dig on a few components. I think you touched on some really great things. One thing is you talked, when talking about obviously the neuromuscular component of it and tone, and also when you think of like the mechanics of gait and what it's doing with those, those resistance bands, we think of a lot of times from a gait analysis standpoint, you look at things like, oh, so-and-so has a lack of, dorsiflexion, and that might be leading to a little bit of a decreased foot clearance when they're walking, or decreased pelvic rotation. And we all know that, when you have limited rotation in the hips, that also can increase fall risk, reduce stride length as well. And that kind of translates into gait velocity and so forth. And so when talking about all these things, I think, in what you mentioned, that this tool can be broken down into different components to be able to help in those different areas. But also, I guess, for someone who may say, hey, well, I might not be able to access this tool or something, with these resistance bands, are there ways to also affect some of those things in the clinically, without this specific tool, or even with the tool? Is there a way for you to manually go in there and maybe change some of the resistance in certain areas, and kind of get more hands-on as a clinician to be able to affect some of those things?
Absolutely. First of all, you could just use bungee tools, put a gait belt on, use a couple carabiners. Now remember, the TheraBand or the TheraTubes they're using are different colors, just like they are. The lightest color is the least resistance. The darker the color, the more resistance. So you can make up stuff to use this. Or let's say somebody just has let's say they just have some hip weakness. You put something around the belt, around the waist, and maybe just help with hip abduction, just to get the pelvis level. The other nice thing is you can go on both sides of the joint. So for example, for dorsiflexion, you can also put a band on to help with plantar flexion, or for toe off. Okay. So instead of just, let's say, a plastic AFO, you only get dorsiflexion. You can almost do it like there's, toe off AFOs. You can kind of simulate what that would do. That's what's nice, because they have an orthotist in the company that kind of helps with that. So maybe you could put an AFO on with the hip stuff. So just to start, let's say somebody comes in and let's say they're just a little weak in the hips. You put a strap around their waist. It could be new gait, or it could be just a regular gait belt. You put a couple bungees on just to give them a little pull, like it's almost like simulating a hip abduction, just to stimulate, just to stabilize the body. It could be as simple as that. You don't have to use everything that's in there. And again, all the tubes, it's like TheraTubes, are different colors for different resistance, different assistance. So, but you can make this stuff up in your clinic or whatever. Or let's say you get a weighted vest.
Yeah, true.
Or put them in a light gate or overhead track.
The next question I wanted to ask you, and this kind of goes into the biofeedback side of this, which is a lot of what these resistance bands doing. They're physically causing a different adaptation, but there's a biofeedback element here, right? And so with that, with any sort of biofeedback, there's always I guess the question that lies is, does that create any sort of dependency for a patient where they kind of rely on that biofeedback throughout those different phases of gait? So I want to ask you that firstly, and secondly, as you're transitioning as a clinician from, hey, we want to use this to obviously help you, but as we're seeing progression, we want to take you away from that so you can be more independent. How do you analyze where they're at in that progression, and being able to say, hey, we should probably take you away from using this more frequently, and then obviously working more on sustained gait with, independently without that biofeedback?
I'm glad I have a good memory, because you had a lot of stuff.
Sorry, I know. I asked a lot of questions.
The dependence thing. Okay. If it gives somebody that assurance that maybe they're not going to be as big up fall risk, okay, you can kind of give them the feel of what it's like. Then let's say they're not taking it home. Then you take them out of it and make sure they're kind of doing well with it. Okay. Or maybe they need an ortho. Maybe they need an AFO before they go home if they were just using it in the clinic. But the key thing about the new gait, which is really nice, is they're trying to use it as a tool. They're not pushing that every patient has to buy it. And they're really good about that. They're not, they're not like the used car salesman type of mentality, which is very, very nice. So let's say a clinic can't afford the whole unit. They could buy just little parts of it or simulate it in their clinic. Okay. That's what's nice about it in terms of that. The second question you asked was, now I'm trying to remember.
It was just talking about, and I'm sorry, I sometimes load them up. it was just talking about, as a clinician, when you see, when you start a patient using this and you see progression, obviously the goal is always to kind of get towards that independent stage. How do you, analyze when you think that, hey, we probably should transition away from using this, less frequently to being more independent with your gait pattern, and without using tools that might offer that biofeedback?
Okay. Excellent questions, Evan. So here's the deal. I think it's an individual thing. You know what I mean? And I like people to be able, you're trying to get symmetry and flow, and you want the patient to flow and do well. If they need it for fall prevention, if they need it to maintain their balance, then it's something you're going to encourage them to either buy or have something similar. But I think we're always trying to use the least amount of equipment. Okay. So maybe this just kind of gets them the assurance they need, put them on a strengthening program, and then maybe they're not going to need it. I think it's so individual in terms of that. And we need to push towards having the least amount of equipment. But what's really nice about the new Gait items is you could just maybe use, let's say, one piece, and two bungees, and then maybe they don't need it. And I think it's nice because I'm sure that New Gait team doesn't want therapists pushing to sell it unless it's necessary. Use it as a training tool. That's what's very nice about it. And then combine it with other things. The other thing is somebody can put on, let's say, a tight girdle in order to get tone around the waist and around the hips. And maybe that's going to do it. And just kind of give them that feel. It gives them assurance. Remember, we always try to give people assurance and give them confidence in what they're doing. And this tool kind of works well with that. And I would just go one other step. It's like when I'm doing a lot of gait, and I've done tons, in gait training and whatever, I like to use perturbations, push them around, let them get used to like losing a little bit. Not the first day, or they'll never come back and see me, or they'll never let me in their house. But what I mean is like push them around a little bit, maybe with a gait belt on, let them get used to that. When babies learn to walk early or move, they keep falling down, right? And they learn from that. Now, we don't necessarily want our patients falling down, or maybe we could do a controlled fall. I think when we do gait training, whether or not we're using New Gait at all, I'm just veering away from New Gait a little bit, do really live, real things. Take people outside, put them on uneven surfaces, use multi-sensory things, tapping their feet. Let's say they don't have real good feeling or don't have really good proprioception, know where they are. Tapping their feet, jumping in a chair, bouncing a ball, like a Swiss ball. Besides people sitting on a Swiss ball and working on activities, I haven't bounced that bigger than a basketball, and then just working on keeping their gait like that. We don't just walk around. We walk around, we carry things, right?
Yeah. I couldn't agree more. I think incorporating, like you said, activities of daily living, experiences that patients are going to be doing on a daily basis is really important. I think sometimes we can kind of overcomplicate it a little bit on the rehab side with what we're doing without realizing, like, hey, sometimes it's as simple as what you said, getting out and having some of those, like, whether it's perturbations, whether it is, getting them on the beach and walking them on sand, which is uneven. If that's something they enjoy doing, you're kind of mixing that, obviously you're mixing the biofeedback of an enjoying stimulus with therapy. So I really like what you said there. The next question I wanted to ask for you, and this is just kind of more on the documentation side and brain of me and understanding reimbursement. A lot of clinicians are doing that daily, obviously. When you're using a tool like New Gait, or it could be other tools, and you're doing standardized tests that obviously fall along with gait and fall risk, whether you think of like the tug or a 5-time sit to stand or a single leg stance. If you're using some of these tools as a conduit for success, how do you go about documenting those things? Is it important to document those things as a part of those tests? I don't know if you have any information or comments you might want to provide there, or if you've done that clinically yourself. I'm just thinking, for people who might be using it through treatments to help, and they might be using it during some of those tests, is it important to document those things? I would think so, but I just want to ask.
Well, no, I think as far as if you're doing testing, like for example, if you're doing a tug, I don't think you should do a tug in a New Gait. because I think you need to see how they are doing it regularly. Now, you could do a comparison, see how they do in a tug, in a new gait, and without a new gait, and then they go, "Oh my goodness, wow!" Then they can kind of see what stimulus what it's helping with, and tell them, education is a huge thing. As far as documentation, I think you got to be careful using specific names, because third-party payers, Medicare, third-party payers, physicians, they don't know what a new gait is, most of them. Or they may. They don't know what some of these tools are. Like, for example, if you put tug, you better put timed up and go. Don't assume people know that. I think you have to be a little careful with that kind of equipment. I would say you're doing multitasking, and advanced gait training. It depends on the state, what insurance companies and what venue, what are you in home care? Are they in outpatient? Are they long-term care? And they kind of know what, so you got to be careful with documentation. However, testing, I think you have to do testing without stuff like this on. Now, as I say, do a comparison, and then you can show the patient, because they like to know too. That's the feedback. Why is the tug so good? Besides it showing a lot of stuff and having so many things in it, multitasking, they have to think about it, they have to turn, they have to recover. But you say to a patient they have a tug of 15, then you're getting close to the range where they're at fall risk, and you say, well, in a week or two, I think you could be at a 10 or 11, which makes you right in the range we want you to be for your age. They go, oh my God, I'm doing better than I thought, which leads to the question. And I think anybody that's been in rehab for a long time, patients think if they're not 100%, they're not better, right?
Of course.
Very often. And, we do. If we're not 100%, nope, no better. And then you have to break it down. And I think using tools like, gait belts and AFOs and Newgate helps them see that. And then they can, they can say, oh my God, I am doing better. Maybe I do need something a little bit. In the Newgate, the nice thing, you can put it under your clothes. You can hide it. If they're a little bit vain about it, if they are getting it for home. So and then the other thing I was going to mention, we want to see what the patient wants to do, right?
Of course.
If somebody's worried about, oh my God, I'm going to be going to a wedding soon, I want to be able to dance, and their balance is terrible, that's a goal. My God, I'm going to a wedding in 3 months. Miss Jones, you're my PT and you're my OT, Mr. Jack. This is my goal. So that's what you need to work towards. Then they're going to be into it, right? So we have to make sure that we're doing what they like. Or they might come up with an idea. Great. I love when patients come up with ideas. It can't be only our idea.
Yeah. And I think too, and we could, this probably could get into a much longer talk, and we won't go there today. But even when you look at, some of the neurological patient populations, when on the top of my head, I think of like a Parkinson's, where you might have some of that shuffling gait or some of that diminished foot clearance. It could even act as a cueing, you know what I mean? Just having that tactile cueing for them to, pick up that foot a little bit, having that resistance, or I think there even, cueing is always really big. We do that, or rehab professionals do that a lot, manually trying to figure out how to add these cues. But I think even having something there on them, on their body throughout the day could be equally beneficial. But I know that's a whole another talk that we could probably get into.
Absolutely.
Well, Shelly, I just want to say thank you so much for joining us today.
Oh, my pleasure, really.
I always love chatting with you and picking your brain, and all of your years of experience doing this. So it's always great. And again, we just want to say thank you for joining us. Those who are tuned in live for this call to talk about gait imbalances and tools that we can use to correct those. And we are doing a giveaway for Newgate's Clinical Mobility Harness Kit. You can access that at rehab.pesi.com/gate giveaway. Shelly, thank you for your time.
Thank you, Evan. Thank you, Bessie, and good luck with whoever wins the prize. Is there more than one prize?
I believe it's just one prize.
Okay. Woo! Good luck.
No, good luck.